Good evening, everyone. We'd like to welcome you to tonight's webinar. This evening's topic is vaccine confidence, the nurse's role in addressing vaccine hesitation. Tonight's session is being recorded and all attendees are muted. We ask that you please stay muted during the presentation. If you have any questions, please type them into the chat box, which is located at the bottom of the screen. You can submit questions at any time during the presentation, and we will answer your questions at the end of this session. Please take a moment and review the disclosure and the conflict of interest slides that are shown on the screen. In order to receive CE credit tonight, participants must register for the activity, log into the session on time, attend the entire activity, and complete the post-activity evaluation. Instructions for completing the evaluation will be given at the conclusion of tonight's presentation. Only those who meet all the criteria will receive a certificate of successful completion and will be awarded 1 contact hour. In addition, our activities nurse planner and all members involved in the planning of the activity have disclosed no conflict of interest. I'd like to introduce myself to all of you tonight. My name is Serena Bumpus, and I am the Director of Practice for the Texas Nurses Association and will be one of your presenters tonight. I'm also joined by my colleague and our TNA Director of Communications, Kanaka Sathasivan, excuse me. I jumble that up every time. I apologize, Kanaka. So we'll go ahead and get started with the presentation tonight. And we'll start with talking about the state of COVID-19 vaccination in Texas. I think it's important that you have some context on where we started and how we got to where we are today. So if you'll recall, we started the COVID-19 vaccine administration 23 weeks ago. It seems like we've been doing this for a while, but we really haven't been. I've had the privilege to be a consultant to the statewide expert vaccine allocation panel, or what we call EVAP, since November. That committee met for the first time on November 12th to begin discussing the plan for vaccine allocation in Texas. And this esteemed panel consisted of public health experts and physicians from across the state, as well as state representatives and senators with a special interest in the health of Texans. That initial meeting, the committee created guiding principles that would help them prioritize the order of populations receiving the COVID-19 vaccine. And starting December 14th was when we began vaccine distribution in Texas. And we began with what we called phase 1A. Our EVAP panel knew that they needed to prioritize the safety of our frontline healthcare workers and our vulnerable and elderly patient populations living in long-term care settings. When Moderna received emergency use authorization, it was then time to prioritize those who were 65 and older, plus anyone who was 16 and older with comorbidities. We knew that 70% of the deaths in Texas were from those who were 65 and older, so we needed to curb that so we could reduce the burden of volume on our healthcare systems. We remained heavily focused on these populations for several months until Johnson & Johnson received emergency use authorization. And it was then that our EVAP announced that teachers and licensed healthcare professionals, licensed childcare professionals, could be vaccinated, and then quickly followed with that 50 to 64 patient population. Unfortunately, by the end of March, we started to see a decline in vaccine administration, which is why we then opened vaccines up to anyone who was 16 and older. And just recently, Pfizer received emergency use authorization to begin vaccinating adolescents who are aged 12 to 15 years of age. In addition, we can anticipate sometime in September that we might be able to start vaccinating children ages 2 through 11. Vaccine trials are currently taking place. And I know Pfizer has announced that they are hoping to get emergency use authorization in that September timeframe. Moderna is also in the midst of their clinical trials in children ages 6 months to 11 years. However, they have not determined a target date yet. So the vaccines that have been authorized for use in the United States are Pfizer, Moderna, and Johnson & Johnson. And just a little background on the three vaccines. Both Pfizer and Moderna received emergency use authorization within just a few weeks of each other. And they both require 2 doses and cold chain storage. Pfizer must be kept at a minus 70 degrees Celsius, which is actually colder than wintertime in Antarctica, if you can believe that. While Moderna can be kept at minus 20 degrees Celsius, which is more like a regular freezer temperature. Both are messenger RNA vaccines, which teach our cells how to make a protein that triggers an immune response inside our bodies. And rather than putting a weakened or inactivated germ into our bodies, that the mRNA vaccine teaches our cells how to produce this protein that in turn will produce antibodies that protect us from the protein that doesn't belong there. And so then we begin to develop an immune response to make the antibodies needed to fight off COVID-19 infection. The benefit, of course, of these vaccines, just like all vaccines, is that we get the protection without the risk of the serious consequences of getting COVID. The Johnson & Johnson vaccine received emergency use authorization in February and received a really warm embrace in the medical community due to the multiple conveniences that this vaccine offered. It was a single dose, which it meant we didn't have to worry about scheduling people to come back for a second dose. And there were no cold chain storage requirements, which meaning it could be stored between 2 to 8 degrees Celsius. And it wasn't such a challenge for organizations or providers to figure out where they were going to get dry ice from and things like that. This particular vaccine is also what we call a viral vector vaccines, which means they used a modified version of a different virus, which is considered the vector, to deliver important instructions to our cells. The vector enters a cell in our body, and then it uses our cell's machinery to produce a harmless piece of the virus that causes COVID-19. And this piece is known as a spike protein, and it's only found on the surface of the virus that causes COVID-19. And so once the cell displays that spike protein, our immune system is triggered and recognizes that it doesn't belong there. And so we have that immune response that we need to build the antibodies against COVID-19. So let's take a look at the impact of our COVID-19 vaccine administration efforts. This slide shows data as of 4 p.m. on Tuesday, May the 18th. And to date, we've administered 20,673,313 doses of the COVID-19 vaccine. We've vaccinated 11,956,686 people with at least 1 dose, and 9,472,575 people have been fully vaccinated in the state of Texas. The map on the slide shows the percentage of Texans who are 65 and older that are fully vaccinated by county. This is an interactive map that allows you to hover over each county respectively to see the percent of populations fully vaccinated in those areas. You can also change the map to actually look at the percentage of patients who have had at least 1 dose. Now, since this is on a PowerPoint slide, it's not as interactive as we would like, but we have provided the link for you in our references. As of Tuesday afternoon, 67.19% of the state's 65 and older population has been fully vaccinated. And the map highlights the counties in Texas that have a higher percentage of this population fully vaccinated. And it also shows those who have a lower percentage. So for example, King County, which is, if you can see my cursor, this very light county sort of up here in the Texas Panhandle. They're the lightest shade of blue on the map, and they currently have 52.19% of their 65 and older population fully vaccinated. Whereas if you come down and look at Fort Bend County, Kleberg County, and Starr County, those are the darkest blue counties on the map. And they have the highest percentage of 65 and older populations vaccinated, which are at 82 and 88%. And then we come to the next slide here, which shows the percentage of our population at ages 12 and older who are fully vaccinated. Now this one is a little lighter in color, and it's, at this time, 39.36% of the Texas state population in this age range is vaccinated. So you can see that we have a little bit of work to do here because we have a lot of lighter shades. We look over here to West Texas, though. Presidio County is leading the pack with 73.24% of their 12 years and older population being fully vaccinated. Starr County in South Texas is also gaining traction in that area as well, because they have 61.24% of their 12 and older population fully vaccinated. So you can see on the map that our biggest area of opportunity is going to be in this eastern portion of Texas, as well as some areas of the Texas Panhandle. We can also break down this interactive map and information and look at our vaccinated populations by age, race, and ethnicity. And as you can see, when we're looking at this from that perspective, we have an opportunity to really make sure that we're capturing our Black and our Asian communities. We've seen a great uptick in the percent of vaccinations within our Hispanic populations. And we need to make sure that we're figuring out ways to capture these other populations. I think we all can take a look at history, and we can look at racism and the subsequent effects, and on the social and economic factors that have resulted in the virus disproportionately affecting our Black community. And because it has hit the Black community so hard, there's a concern that vaccine hesitancy is going to perpetuate the health disparities amongst this patient population. And so recent studies have actually shown that the Black community does have the highest levels of individuals who state they will never get the COVID-19 vaccine, or that they're not sure if they're going to get it. And this is largely due to distrust within the medical profession and in the government. And so we have some opportunity here to really get creative and really engage with this particular patient population. As a whole, we've also seen a rapid decline in the number of vaccine administration. We gained great momentum starting, from December all the way through April. However, that rapid decline hit as the Johnson & Johnson vaccine was recalled due to the concerns of a certain percentage of the patient population getting blood clots and needing to do a further investigation on that. Providers are reporting that there are many of their patients who do not want to take the Johnson & Johnson vaccine despite its availability and its convenience of only needing one dose. And in addition to that, many people are skipping their second shot, which is also impacting our total number of Texans who are fully vaccinated. So the EVAP panel and state leaders are really looking at creative ways on how we can get more people vaccinated to bring these numbers up, rejuvenate that momentum that we had early on. And so many of our drive-through hubs have stopped their operations, and they're either have taken the vaccines and are beginning to administer it to patients within their facilities. They're creating mobile vaccine clinics and setting up these clinics in non-traditional areas that we can talk about here in just a few minutes. They're also allowing physician offices and other providers to order the vaccine so they can administer it in their clinics and for the ease of convenience with their patient population. So there's a hope that this will make the vaccine easily accessible to Texans. And this is a map that just shows how Texas compares to the rest of the United States. And this shows where Texas is with total doses administered per 100,000 of their total population. So what is it going to take to achieve herd immunity? We know that it only occurs when there's enough people who are immune in the population, and that's the only way that we're going to be able to disrupt the transmission. Experts are saying that they're estimating anywhere between 60 and 90% of the US population would need to be immune for us to actually achieve herd immunity. But there are a lot of factors that influence our ability to achieve that 60 to 90%, which includes how well vaccination and prior infection prevent illness, and also how well it prevents just transmission to others. Other things that are going to lead to failure is vaccine hesitancy. If we can't work to help others feel comfortable and confident in getting the vaccine, that will be a potential barrier to achieving that herd immunity. And now that we are able to vaccinate adolescents starting at age 12, this does help to some degree in achieving herd immunity. And then hopefully, once we are able to start vaccinating the population below the age of 12, that will also help us get there as well. So why are people hesitant to get the COVID vaccine? There is definitely a lack of confidence in the vaccine. That includes the concerns about vaccine safety. There's skepticism about the healthcare providers and public health officials who are administering them. And there's still a degree of complacency out there that, people still don't think that COVID-19 is really all that big of a deal. And so all of these things lead to people not wanting to get the vaccine. In addition, there's a convenience factor, and we have to make getting the vaccine much more convenient than we have in the past. I love this graphic here, and this is actually a graphic that was produced from a national survey that was recently conducted of adults in the United States regarding vaccine hesitancy. And the survey participants were grouped into distinct profiles based on their shared beliefs and barriers to the vaccine. And this is what they called psychobehavioral segmentation, which essentially allows healthcare officials to target strategies in a way that will ignore demographic categories, such as age and race. This approach was used in this particular study to identify 5 distinct personas. And those personas include the enthusiasts, the watchful, the cost anxious, and the system distrusters, as well as the COVID skeptics. Though these people in each segment shared some beliefs and barriers about the COVID vaccine, and then they also took some demographic data into consideration, such as political affiliation, race and ethnicity, socioeconomic status, and age. And when they looked at this, there were, out of the 5 groups, there were 4 that we have to figure out how to reach and address their concerns and fears and barriers to getting the vaccine. And so they were able to break this data down by state. And so of the survey participants, this is the data and the percentage of Texans who are either in that watchful category, cost anxious, system distrusters, or COVID skeptics. So when we talk about the COVID skeptics, they're those who are really at the far end of the spectrum. They're deeply grounded in their beliefs about COVID-19. And almost everyone in this group believes at least one conspiracy related to the pandemic. That's anywhere from they're going to implant a microchip in my arm, or to the government is just exploiting the virus in order to gain control of us, or also to the pandemic being caused by a group of ringleaders who are trying to manipulate the world. The key to engaging with this group is to avoid trying to debunk what they believe. Instead, we need to listen, we need to acknowledge and share the facts. And Kanaka is going to go into these tactics later in the presentation. Then you have our cost anxious group, and they're worried about the time and the potential expense of getting vaccinated, even if it is free. This is even more prominent in states who have high poverty rates and low Medicaid coverage. So it's critical that we bring the vaccine to this group of people. And that's where we're going to hold clinics in those non-traditional, non-healthcare locations that people frequent, such as their workplaces or their church, daycares, grocery stores, bars, restaurants. This is where we really have to get creative in order to reach this group of people. It's going to be important to stress to the cost anxious group that the vaccine is totally free. And then we also need to work with our businesses and community partners to ensure that they're providing paid time off to their employees so they can get both doses should they choose to get the Pfizer or the Moderna vaccine. When we talk about the system distrusters, they're not just, they're distrusters. They believe that the healthcare system is unfair. And the majority of these members are people of color. And we really want to engage this group by holding formal or informal conversations with trusted members of their own community to air concerns and to be transparent about efforts to vaccinate underserved communities. This group has really low expectations that other people in the communities are going to get vaccinated. So therefore, making vaccinations of people that they know in their communities and people that they trust in their communities is going to be incredibly important to bring this group on board. And then we have the watchful group. And they're the ones who are holding out to watch and see the experience of their friends and their family and their neighbors before they really commit to getting the vaccine. With this group, it's going to be important to establish norms with them. They can lead to accept and persuade the watchful to get the vaccine. The watchful are already likely to comply with the public health guidelines, such as masking, and which shows their intent to comply with those social norms. So it makes it a little bit easier to get this group to respond to our messages about getting vaccinated and getting vaccinated to protect others. So it's very important that this group has the option to opt in and they'll get the vaccine in their own time. So why do nurses play such an important role in helping us communicate with those 4 groups of individuals? And first and foremost, we're the most trusted profession, right? We've had that title now for 19 years, and it's one that we should be very proud of. And so we need to leverage that. We need to leverage that trust and use it to influence these populations and these groups of people to get the vaccine. We're leading the way, and we want them to follow us. The work that nurses did throughout the COVID-19 pandemic has further strengthened that trust within our communities. And the more we can leverage that to influence our family members, our friends, and our neighbors, the sooner we'll be able to get back to some degree of normalcy, which we are moving in that direction, and to achieve that herd immunity. We have the ability to educate and debunk the misinformation that's out there. Well, not debunk, but to really ensure that people understand what the vaccine is capable of doing and how it isn't harmful to ourselves and to others. And so using our trust and our influence to do that is critically important. I'm now going to turn the presentation over to Kanaka, where she will talk to us about strategies to increase that vaccine confidence.
All right, thank you, Serena. So I thought we could start off with this example of what not to do. This was making the rounds on Twitter a few weeks ago. And some people thought it was funny, but a lot of people, nurses and doctors and other people in public health, were fairly horrified by this video. So I'm just gonna play this for you, and hopefully the sound will also work.
I know there are between 60 and 100,000 miles of blood vessels in the human body. I know that because I've studied human bodies.
Did you know the human body has 205 bones? Well, you're wrong. It's actually 206.
I did know that because I'm a doctor.
Did you know that eating raw ginger cures cancer? You didn't? Good, because it doesn't.
I've saved people's lives.
I've cracked open a chest and manually beat a human heart.
I've even delivered some babies in the back of cars.
Do you know how many people have shown me weird skin things at parties and asked me if they were dying?
Too many.
My life is spent trying to improve and save yours.
Oh, but you read something on Facebook?
Your friend from high school who sells jewelry, she posted it?
The one who's 53 and still builds dollhouses?
You heard what? On whose podcast?
Is he a doctor? No? Scientist? No?
Can he name one of the ingredients in the vaccine?
Can he point to his gabella?
Then tell him to shut the up. The Gobella's right here, by the way.
Isn't that polio shot we gave your kid?
So that was a little snippet. The whole video is 3 minutes long. And you can, I think it's on Jimmy Kimmel's YouTube page if you want to go watch the whole thing. So just looking at that video for a second, I think most of you might have had the same reaction as me. The doctors and nurses and technicians that were in that video were really judgmental. They were fairly condescending. They were talking down to their audience. None of these are really the way to convince people to vaccinate. This video, in fact, and a lot of the comments that I saw also happen to trigger people that have medical trauma in the past. So, you know, it can go even further than just not convincing people. It can actually convince them in the other direction to not trust doctors and nurses and not get vaccinated. So these are the real keys to communications. If I was advising the people that made that video, here's where I would start from. So meet people where they are. You notice that when Serena and I have been talking about the people that we're trying to get to take the vaccine, they're vaccine hesitant. Many of them are not anti-vaxxers or anti-science, but this entire process of how COVID-19 has been handled with, stay-at-home orders and masking and just the back and forth between different health entities and different government agencies, All of it has kind of played out very publicly. And so people are very hesitant to now get a vaccine when they didn't really understand the process of how it was developed or understand why it's safe and what the benefits of it are. So they just want more information before making a decision. And as that great breakdown that Serena had showed, there's the COVID skeptics, there's the cost anxious, there's the watchful, and then there's the distrusters. And we're going to go over how to figure out which group someone falls into, and then also how do we address those very specific concerns that they have. So the second thing is validate people's feelings, build trust. I think nurses are experts at this. Nurses in general are very good at getting to know the patient. There's an art to, learning what their fears are and comforting them when they're undergoing a scary procedure. Those are the same skills that you'd be using in this case. So make sure they understand their fears are understood by you and they're legitimate fears. It's not shameful to have those concerns or those fears. And the choice to get vaccinated is a personal decision. None of us want to bully people into getting vaccinated. We want to understand that it's a personal decision and help them make a decision that's going to be right for them and their families. And a health provider can really only provide information. We can't make the decision for them. So we want people to listen. We want nurses to listen actively to their concerns and address those concerns one by one. And as Serena said previously, many people of color have good reason to distrust medical professionals. Others might have prior medical trauma, particularly people with disabilities. And so nurses need to earn that patient's trust. And especially if you work in a clinic where you're seeing the same patients regularly, that's a great way to continue building that trust. And let's say you're part of a community like a church or another religious group, you already have some trust built in. And so those are ways that you can leverage existing trust to try to educate people. And then be transparent. The vaccine development process happened quickly, but it was still conducted safely. No steps were skipped, but we were able to get immediate funding, which is really what holds up a lot of the vaccine development process. But they were able to have immediate funding. They were able to overlap some of the phases, and they were able to get that data, the 2-month data, to the FDA very quickly for the emergency use authorization, and they now have enough data to go for full authorization. So hopefully that's enough information so people are less afraid of how quickly the vaccine was developed. And then just understanding there are risks with the vaccine. We can't just pretend that that it's the right choice for everybody. There are risks. Some people have gone into anaphylaxis, and then others have had extended fever or pain in their arms, and especially if you work a physical job, if you can't get days off, all of those are concerns. And then the racial inequality, as Serena has already touched on. Some of the groups that are the most affected by COVID are also those that don't always have easy access to the vaccine and may not understand the risks with getting the vaccine versus getting COVID. And so all of these have to factor into the way that you educate people. And know the facts about the vaccine. Dr. Ernst Grant said this very early on in, I think, December, but nurses need to educate themselves so they have the most accurate and up-to-date information. And you guys are already doing that by attending this webinar, so thank you for being here. But just being able to sit down and answer questions or concerns that people in the public may have. And like I said, being transparent, that's one of the things he mentioned as well. Also, at the very end, what I didn't include in here is that we can't just talk about the vaccine in isolation. So just like a car has both airbags and seatbelts, vaccines are just an extra tool along with masks and general hygiene that keep us safe. And simply getting the vaccine is not going to fix a lot of other issues that affect health, like the social determinants of health and that racial inequality that also puts those groups at higher risk with COVID. Just getting a vaccine won't solve any of those systemic issues. So we have to be realistic about what the vaccine can and can't do. So I'm going to go through a couple of behavioral science theories here. So hopefully it's not going to be overwhelming, but just so we can understand all of the factors that influence these decisions. Not every person is the same. So we're going to go over 2 of these health theories today, but the limitation is you can't really use them in every situation or assume that every person's thought process is the same. They're a good starting point, but the tool that nurses will really have to rely on is motivational interviewing. And if you visit our website, texasnurses.org, we actually just 2 weeks ago published something on motivational interviewing. And you can use those same techniques with vaccine hesitancy and vaccine confidence. So a lot of the data that we have about the COVID vaccine in particular is also from other countries. So take those studies with a grain of salt when you see them in the news. They might not really apply to the US or Texas population, especially those minority populations and those that are most highly affected by the social determinants of health. But it still creates a little framework for us to start from. So the first thing, I'm trying to advance, there we go, okay. So the first thing to look at is risk perception. That's going to be the major driver of the decision to get vaccinated. And risk perception is affected both by knowledge and emotion. So simply just knowing that the vaccine is safe is not going to be enough if you've heard dozens of stories from your friends and families about horrible side effects. Someone who doesn't want the vaccine, they've probably consciously or subconsciously done this risk assessment for themselves. And they've decided they would rather risk COVID than risk the vaccine. So let's say they're working from home, they get all their food delivered. Do they really need to get the vaccine immediately? Maybe not, because the risk is fairly low for them. So this is the health belief model of behavior change. And this is a good framework for understanding individual beliefs that affect any sort of health choice, such as getting vaccinated. And it essentially boils down to whether the person believes the risk of COVID-19 is worse than the risk of the vaccine. So are the risks of getting the vaccines worth it? Another thing that you can see on here is, so it says in the middle there, perceived susceptibility to the disease, will they get COVID? Perceived severity of the disease. If they're on the younger side, is COVID really going to be that bad for them? And then perceived benefits of vaccination. They'll get to see their family again. They might get to go out to restaurants again. And then perceived barriers to vaccination. So here is where some of what Serena was saying comes into play. So the barriers are really a place where nurses can do a lot of good to change people's perceptions. So one thing is that not everyone understands that the vaccine is easier to get now. We have a surplus of vaccine in Texas currently. And there was a lot of scarcity at the beginning, so people may have given up trying to get something in January, February, and just not even thought about trying to get it again. So understanding that it's easier to get. If you don't have a computer, if you don't have a smartphone, you can now call your local pharmacy. I know for a long time they were directing people to their websites, and that was pretty impossible for someone who doesn't have access to technology. So you can call your local pharmacy. And then I just heard HEB and other places are now doing walk-up vaccines. So someone who is picking up their groceries can just go and get vaccinated at the same time. DSHS has also shifted. Previously, they were shipping out hundreds of vaccines to hubs, and now they're shifting to shipping out smaller doses of vaccines. So now clinics and doctors' offices can order these smaller doses of vaccine so that people can go to someone local or their primary care provider to get the vaccine. Other major perceived barriers that Serena also included earlier on is not having insurance, not having a government ID, not knowing that they're eligible to get the vaccine. So we really need to put that message out there. The vaccines are free. You don't need to have insurance to get them. And everyone's eligible at this point. 12 and above is eligible to get the Pfizer, and 18 and above for the other shots right now. And the insurance and the ID, I think, have thrown a lot of people off, because when I walked into the CVS to get my vaccine, they asked for both of those items. It's not required, but it also made it easier for them to track, make sure they're spelling my name right, make sure they've got my birthday right, put it into their system and track that I've got my first dose, that I get my second dose at the right time. So people may not understand that they're not required to have an ID. They're not required to have insurance. It's just that makes the tracking a little bit easier for the people entering the data. And I've heard cases of people who have been asked for ID. They like did all the work to get an appointment. Then they're asked for ID and they turn around and walk out because they don't have ID on them that they want to share. So we really need to break down that perception and help people understand that these aren't things that are required to get the vaccine. Another study that was done in the US also found that people perceived that getting the vaccine would be expensive or that it would just be completely inconvenient. So that was another predictor of unwillingness to get the vaccine. And students in particular, another study found that the ones who were willing to get vaccinated had engaged in a dialogue that included the benefits of the vaccine, and they had seen changes in their environment that made it easier to get the vaccine. So when those barriers are addressed and when people can get a better sense of that risk perception, then they will change their minds and choose to get vaccinated. So especially that younger group, I find that study interesting because that younger group is really not getting vaccinated at the rates that older adults are. So that's one great opportunity for nurses to get involved. So when we look back at this, the individual beliefs in the middle, they're influenced by these modifying factors. So age, like we just talked about, gender, location, ethnicity and race, as we talked about earlier. And then income and wealth is also an influencing factor on the things that people believe, which is in the middle. And so all these beliefs, they lead to individual behavior, which is that last box. All those beliefs taken together drive that behavior, and that behavior can be influenced by cues to action. Cues to action include media campaigns, social media, reminders that come from their providers, and then their own experiences with COVID. And so if we can get nurses to contribute to those cues to action, encourage your friends and families to get vaccinated, give a presentation to your church group, anything that you can do to kind of trigger people, spur people to go out and learn more will help. Everything kind of adds up that way. So that is the health belief model in a nutshell. The next one is the socio-ecological model. We're not going to talk too much about this one, but this basically breaks down that individual risk perception even more into the different levels that influence people. And normally you see this model as concentric circles, starting with individual at the very middle, and then going all the way out to the public policy. Oh, I'm sorry, I did not advance the slide. Okay, there we go. So the largest levels, we have public policies, that's requiring vaccines for school children. At the community level, we have organizations like TNA setting an example, or even businesses that require vaccines for entry. And then that institutional level, that is one that has a lot of influence because it's closer to that individual person's decisions. They may be persuaded by seeing all their peers get vaccinated. They may feel pressure from their employer. And then we've got interpersonal. What are their friends and family doing? How did they view the decision to get vaccinated or not? One study in Israel found that these norms in your interpersonal circles really influence who chooses to get vaccinated. And they were especially driven by two statements. Most of my friends will support the COVID-19 vaccine. And if I tell my friends and relatives that I intend to get vaccinated, they will respond positively. So people who already had those beliefs in their circle of friends and family were more likely to get vaccinated. And then the most narrow part of the model, the individual. So this is what we were talking about in the previous slide. What knowledge, attitudes, skills, and perceptions do they have? What's their history with the medical establishment? Do they have enough self-efficacy to complete all of the different steps to getting vaccinated? So a lot of the public health initiatives are going to rely on every level of this, and DSHS is absolutely applying all these to all the campaigns that they're doing. And where this model works for nurses is with motivational interviewing, as we said. So find out the influences in your patient's life that affect their decision to get vaccinated. What are the large influences, the small influences? What's their own personal motivation for getting vaccinated? And then you can help them do a risk assessment. And you may also want to consider, part of this is also, if people who lean a certain way politically, people of color, people with particular health conditions, or a history of medical trauma, as I mentioned, they just might not be receptive to being told to get a vaccine. So that motivational interviewing and the risk assessment can really do wonders for getting people to give the vaccine another try, I guess, another thing. So where do we start? Having the conversations. Put the truth and the solution front and center. We'll come back to this a little bit later, but it's first on my list because it's the simplest thing. Avoid stating the myths out loud, because studies have found that when you repeat those myths, they tend to get cemented in people's minds. So just talk about the facts instead of the myths. And then be confident about how safe and effective the vaccine is. And hopefully we can answer a couple more of your questions today. So if you have doubts yourself, we can clear those up for you too. Like we said before, avoid jargon and don't shame. That video of what not to do, it really just creates a barrier to trust, and it magnifies an existing power imbalance. So when people come in to see a nurse or a doctor, there's already a power imbalance there. And so they already have a little bit of, especially some people might have some mistrust because of that power imbalance. So we don't want to create that barrier. We want to break it down and build trust. And then make it personal. So find out what their motivation is. Maybe they want to see more of their grandkids. Maybe they want to stay out of a hospital in the future. Tell them what they're going to gain from getting the vaccine rather than the negative of what they're losing out on. And then we've also heard a lot of stories from nurses who went out of their way to make the vaccine accessible. So nurses that went to people's homes door by door, who used a mobile clinic to get vaccines out to rural areas, setting up drive-through clinics. So all of this can help, especially for people. There's another subgroup of people who are not vaccine hesitant, but they are hesitant about going to a public place to get vaccinated. They don't want to have to spend 20 minutes in a crowded pharmacy waiting to get their vaccine and then sitting there waiting for if there's a reaction or not. They see that as too much exposure to COVID to be worth getting the vaccine. So offering the vaccine in different ways and breaking down those barriers, making it accessible in multiple ways will help that. And then make sure the message is ongoing. In marketing, they say you need to see something 7 times. Some people say 10, some people say 20, but regardless, you need to see something a ton of times before you actually commit to it, before you actually purchase that car or buy that shampoo or whatever it is. And marketing is based on really similar cognitive theories to the ones that we just discussed. So exactly like you would convince someone to buy a brand of makeup, it's the same thing you do to convince someone to engage in health behavior. Make it ongoing, make it repeated. It's a consistent message from trusted sources. And as Serena said, nurses are the most trusted source. At the very end, it says, make a strong recommendation and be presumptive. This is kind of the trickiest part, in my opinion, but studies show that this method really, really works. So what nurses need to do here is just be straightforward that you recommend the vaccine. And rather than asking if someone wants a vaccine or not, presume that they're going to get it or that they're interested in getting it rather. So you might say something like, I'll be right back to give you your COVID vaccine so you'll be protected. Or, as your nurse, I highly recommend getting the COVID vaccine today, so we'll go ahead and get one ready for you. Then at that point, if they express hesitancy, you can go through the whole motivational interviewing process with them. Sometimes, in many cases, it's really just, taking the decision away. Some people just, they don't want to be faced with doing that risk perception and doing the decision and all of that. So when the nurse comes in very confidently and says, hey, we've got you scheduled for that tetanus shot, I'm going to get it ready for you so you can get out of here. People are happy to take it. So that's another way that if nurses can get into that habit, that type of language, that can help a lot with vaccine hesitancy as well. So these are some of the major concerns, and several studies have been done very recently that have come back with these similar themes over and over. And one thing to remember is it doesn't really matter if the concern or belief is real or misinformed. So the concern about vaccine side effects, those are real. The concern about 5G microchips, that's misinformation. But either way, it doesn't matter because the person is still making the same decision to not get vaccinated. So going in, being transparent, being non-judgmental, that's really the place to start with everybody. And then use motivational interviewing, help them verbalize their concerns and beliefs. And then you can work through that decision together. You can also find out what their values are and their current knowledge level. Maybe they just haven't heard enough about the safety or the studies done on the vaccine. And then, like I said before, connect getting it to what they prioritize. Some people want to protect their community or protect their grandparents. And then offer them new information, like the new studies show the vaccine is safe during pregnancy. Those are actually some really exciting studies. They also showed that once the mother has immunity and then gives birth, that immunity is passed on to the baby. So that's really good news for infants as well. So refocus them on the good that the vaccine can do. And again, here's some beliefs to change. And I did see in the comments about the insurance information, and hopefully Serena can address that a little later on, but the need for insurance, the financial burden of it, and then being a test subject for a vaccine with unknown consequences. This is a big one. And I would say personally, I thought the studies were well done and there was enough data to show that there wouldn't be a lot of unknown consequences. But that's something that I know as someone who works in this field and has been hearing about the vaccines since before they were released. And somebody else might not, and especially if they're seeing people pop up on the news saying, well, I was sick for a month after I got vaccinated, all of that influences them. So finding out what those beliefs are at first, and then knowing how to change them is the second step. So these are your three basic things. Know the facts, repeat the facts, frame the facts. So that basically sums up everything we've talked about. Face the infodemic, that is a term from the World Health Organization and is a catch-all for the misinformation that is thrown at people daily from a multitude of sources. And knowing the facts is the best way to combat it. One thing is that a lot of this information is actually put out there deliberately by a few small actors that are responsible for most of the misinformation about vaccines. And it's put out there deliberately. They use social media very deliberately to get that message out. So even telling people about this can help convince them that the vaccines are safer than they've heard about. And the World Health Organization and other organizations that are studying this really emphasize that we need to amplify trusted sources so that we can drown out all of that misinformation. And so that's another place that, even if you don't see patients daily, or even if you don't have time to go out to the community, you can share those trusted sources on social media. You can make sure that your friends and family see them and that they share them. So fighting that infodemic is one of the biggest challenges with any vaccine. And I know that we're also facing a challenge where a lot of children have missed out on their general vaccines that they need for school. So there is going to be a big push over the summer to get them caught up. So nurses have a huge role to play in that as well. And it all goes back to this, knowing the facts, repeating the facts, framing the facts. And with framing, remember that getting vaccinated is not about politics. It's about the well-being of all of our communities across Texas. And so just really continue driving that message home. All right. So these are some of the questions that we've just gotten in general over the past couple of months. But we would like to open it up for questions from the audience. And also I want to remind everyone that we have all this information is generally on the website at texasnurses.org/COVID-19. And also, if you haven't yet downloaded our mobile app, it's the Texas Nurses app. And all the one-pagers are going to be in there to English and Spanish. And our school safety one is also in Vietnamese, since we have a lot of Vietnamese families with children that are going back to school in the fall. So please do download those one-pagers, print them off for your patients, and use them as widely as possible. I'm just looking through the chat here, and there are several people saying that they had to provide their insurance information so the pharmacies could get reimbursed. So Serena, can you speak to that?
Can you hear me?
Yes.
Sorry, okay. That really is, so the insurance information from the federal pharmacies, as I understand it, is so they can actually bill the provider, but your vaccine is still free. You don't have a copay. There's nothing that you should have to pay out of pocket. And if for whatever reason someone doesn't have insurance, that's okay. It should not be a required field. They should be able to leave that blank. And it shouldn't prevent anyone from getting the vaccine, because no one is going to be billed for that. If anything, on the back end, it will be the insurance company that's billed instead.
We had another question, which was, as primary care offices now that we can get the vaccine, we don't want to waste the vial. So we want to have enough patients interested to not waste the vial. Any chance that pre-filled syringes or single dose vials are in the works?
That's not something that we have heard of. However, in the expert vaccine allocation panel, those conversations have taken place. And the message is, you know what, if we have to, at this point, because we need people to get vaccinated, if you have to waste vaccine, then waste it, because that means one more person is still vaccinated than not. And as painful as that is to say, considering we didn't have enough vaccine early on, we're now at a point where we just need to get vaccines in arms in any way that we can. But at this time, there is no, there's not any plan that I am aware of for pre-filled syringes. And that probably has a lot to do with the storage of the vaccine itself.
So Ruby had a question. What should you say to an individual who says, I have an autoimmune disease, and I have read that if you have an autoimmune disease, you can lose the immunity you already have? So that's actually a new one. I haven't heard that one before. But I do have friends with autoimmune diseases. And I know that in some cases, I think in all cases, I would say talk to the doctor that manages that, whether that's a rheumatologist or someone else. Talk to that provider specifically, because they can give the best advice. But there's also different ranges of autoimmune diseases. And I think in general, I don't think that the way that the vaccine works is by teaching your immune system how to recognize the virus, and then the immune system can store that in its memory. And I think I would explain it to them that way. So it doesn't make any sense that the immune system would forget about something it's already seen because it's learned something new. So just like, if I see a daisy and then I see a rose, I'm not going to forget about the daisy. It's the same thing with the immune system. They're not going to lose immunity that they already have by getting the vaccine. So hopefully that's kind of one way that you can start that conversation. Another question from patients. I already had COVID. Why do I need the vaccine? So like I just said, the vaccine has been shown to do two things. It creates antibodies, which is kind of that short-term, that trigger for your immune system to fight the virus off. It also creates long-term memory, and it creates a memory and immune response to a very particular part of the virus that almost all the SARS viruses and variants are going to have. We haven't seen a variant yet that the vaccines did not respond to, I believe, that have been tested so far. And so it's a little more controlled. When your body naturally fights off the virus, it could be responding to any one of 100 proteins that are on the virus. And you don't know if the next virus that comes along is going to have that specific protein that your body created a memory against. And so with the vaccine, you can create a very specific memory. And the researchers were careful to choose something, and what they call it is conserved. So it's conserved throughout multiple generations of the virus. As the virus replicates, the spike protein remains pretty much the same the whole time. And so that's why they chose that protein to make the vaccine for. And so it's much more targeted than the general immunity that you might get from just having had COVID. And you don't know if that immunity will last very long, but we do know that the vaccines create memory cells. And so we do know the vaccines will last longer than just regular immunity that you get from COVID. So some healthcare workers are skeptical about the vaccine and how can they convince patients to get the vaccine. One thing that we have heard a lot from nurses is we know how vaccine development works. It takes 5 to 10 years to make a vaccine. Serena, do you remember about the measles? Was it 4 years or was it longer than that?
It took 4 years for them to make the measles. Yeah.
Yeah, and so that measles vaccine was probably the last one that most nurses were familiar with the rollout of. And then probably the HPV vaccine was another recent one, and that one also took many, many years of development. So I've heard a lot of nurses say they were worried about how quickly these were developed. And the two biggest things I have to say is remember that mRNA technology has been in development for 10 years. And then SARS vaccines and SARS, the study of the SARS viruses has been going on for about 20 years. We almost had a vaccine ready to go in 2006, and they just ran out of funding. And so really the only difference with these vaccines, actually I've got it on this next slide, the biggest difference is that the funding came in very quickly. They were able to overlap the phases, and then they were able to get them into production as they were getting them approved at the same time. So the second they were approved, those vaccines were ready to ship out to places. And so that's why it was able to be condensed down into a much shorter time frame. And then at the top, you can see this is the 10 to 15 years where it happens linearly, it's not overlapped, and they have to apply for funding between every single phase. You finish phase 1, you get your results, then you apply for funding. You have to wait for that funding to be approved, and you have to talk to funders, go back and forth, get the money to come in, and then start recruitment for phase 2. And just imagine that all of that was taken out of the mix, and they were able to do these phases very rapidly because they didn't have to deal with that back and forth for funding. So that's the biggest thing that I would say, especially to nurses that are skeptical, because the development timeline is not really, shouldn't really be a concern. I understand why it's a concern, having seen all these other vaccines that take years to decades to create. But the timeline for the SARS-CoV-2 vaccine happened quickly because of funding and because researchers were prepared. They had the bones of the mRNA vaccine ready to go. The second the genetic code was published, they created the vaccine the next day. So they were just ready to go, waiting in the wings to create this. So hopefully that will put some people at ease. And I know that long-term side effects are another question people have had. And with that, remember that the first person to get the vaccine got it in March of 2020. So they've been vaccinated for 15 months now. And, nothing's happened yet. So I think that's a really strong evidence for this vaccine not really having long-term side effects. And in general, long-term side effects will show up within 6 weeks of getting a vaccine. So in previous vaccines, like with Guillain-Barré, I can never pronounce that right, the GBS syndrome, it shows up within 6 weeks. And we know that these trials followed people for 2 months before they were even able to submit the data to the FDA. And now they've had enough trial data to submit for full approval. So hopefully that will convince some of the people that were just kind of waiting to see how much data would come out later on. The media has shown that some people have contracted COVID after receiving the vaccine. And then the efficacy between the mRNA versus the viral vector and J&J versus Pfizer and Moderna. Serena, do you want to talk to that at all?
Yeah, this was something that was sort of hidden on one of the very first slides, but you know, the Pfizer and Moderna vaccines have very similar efficacy rates where Pfizer had showed to have a 95% efficacy, whereas Moderna showed to have a 94.1% efficacy, which is really, really high, and something that was it made everyone very excited because those results were so positive. And the J&J also has shown to have a 66.3% efficacy, and that efficacy rate has also varied a little bit depending on where the clinical trial was. I know there was I believe a higher rate of efficacy in the UK. So really overall, if you were to combine the trials that they've had taken place around the world, there is a little over 70% that they've of their efficacy rate with J&J. So all of them have proven to be very safe and very effective in preventing COVID disease. And we still have other manufacturers who continue to conduct trials, and there will be additional availability sometime in the near future.
And then as far as contracting COVID after getting the vaccine, I think that can happen with any vaccine, really. They're not 100%. And what's really crucial is getting to that herd immunity point where we can stop transmission. Even the measles vaccine, which is highly effective when we have herd immunity, but the second herd immunity drops below, is it 92%, something like that? The second it drops below that, people who are vaccinated will get measles, and it happens in outbreaks a lot of the time across the U.S. So I think that's going to always be a risk until we get to the point where we can stop transmission, or at least slow transmission, and also slowing transmission means slowing replication and slowing the amount of variants that come up. So all of that is going to go hand in hand with keeping people protected. So I think, yeah, a handful of people are going to contract it after getting the vaccine since it's still circulating.
And I was also going to add that, sometimes the media creates clickbait for us, or their headlines over exaggerate reality. And so it's up to us to not just stop at the headline, but to go in and read the story as well. And because we are the most trusted profession, and we are looked to as people who are able and capable of educating individuals about the virus, we can take advantage of getting in front of the media to educate them as well on the importance of making sure that their headlines are correct. And I know I personally have reached out to some media partners to say, come on, that's not fair. This is, you have to work with us and not against us. And so if the more nurses do that, the more we can make an impact too.
And then Lorraine had a specific question about PFABA, and that is not a condition I'm familiar with. Are you, Serena?
I am not, and I would say that if there's any question about any sort of autoimmune condition, that's definitely a conversation that the patients and their families want to have with their providers to decide what the best course of action is for that particular individual.
Yeah, and also the consideration for people on immunosuppressants, depending on which immunosuppressants they're on and the reason that they're taking them, they might be counterindicated for the vaccine. And then can patients choose which vaccine they want? Pfizer, Moderna, J&J?
Absolutely, they
and
can.
They have been.
They sure have.
Yeah,
I think the great thing is we now have a lot of resources for those who have access to the internet, where you can go on to the Texas Department of State Health Services COVID-19 website, and they have a vaccine finder where you can essentially go in, you put your zip code in, you can pick which vaccine you want, and it will tell you exactly where that vaccine is located inside your community. Now, it's not always fully up to date because it's also very dependent on the provider and making sure that they get their information entered in timely. But it does give you an idea of who provides those specific vaccines. So you can begin to really look at, in trying to schedule an appointment with them.
Will the vaccine need booster shots each year? This is something that is a possibility, but I personally think it's been a little overblown in the media. There are some people saying it's for certain that every 6 months we're gonna have to go in and get a vaccine. And I think right now it's up in the air. We need to see how long immunity lasts. Like I said, some of those early phase 1 participants, that was last March, and they're still following them. So hopefully we'll have that data soon on how long immunity lasts. And the other thing is we have to get as many people vaccinated as quickly as possible to stop the variants. That's going to be another thing that, if another variant comes out that can evade this vaccine, then yes, we likely will need a booster. And that's kind of the case with flu vaccines because there's so many, over a dozen flu viruses. If we can get people vaccinated quickly, keep the variants down, I think that'll also keep down the chance of getting boosters. But it's still a possibility. I mean, we have to get tetanus every 10 years. There's lots of vaccines that need boosters. So hopefully that won't keep anyone from getting vaccinated in the first place. And then Pam asks, can we mandate vaccine requirements at colleges since it is not fully approved? And Serena, I know that DSHS had originally said, well, this was about employers. So I think it's slightly different legal areas. But I think Serena can go into that.
Originally, when the vaccine first received emergency use authorization, that the state had taken a pretty strong stance that we didn't want employers or anyone to mandate the vaccine. One, it was not going to build trust within our healthcare systems and our providers. And so we needed to make sure that we did have that opt-in option for everyone. And now that more and more people have received the vaccine and it's proving to be effective, that legally, we've learned that legally we know employers can mandate their staff to get the COVID-19 vaccine. We've seen that with some of our healthcare systems here in Texas, and I anticipate that more and more will begin to make that a requirement. As far as colleges go, I have not heard of any colleges mandating that, and I honestly, from a legal aspect, don't know if they are able to do that. I do know that the state is working with our colleges to make the vaccine readily available. Right before the Johnson & Johnson vaccine was recalled, the state was looking to work with colleges to try and get as many of their students vaccinated with that J&J vaccine before they went home for the summer. Because it was one shot, they didn't have to worry about bringing people back to get that second vaccine or wondering if they got it when they went back home. But then the vaccine was recalled and now everybody's out of school. So, it'll be interesting as our universities prepare for students to come back in the fall, what that might look like. And I think there will be more to come from that perspective.
Yeah, and I don't know that I've heard of any Texas colleges, but I know that other colleges across the nation are requiring vaccines. And it might be the case that at least Pfizer gets full authorization by the fall. So it might not be in that legal gray area as much as it is right now.
Right.
All right. And then I was just going to really quickly, I think we covered most of what's on this slide, but the pregnancy, lactation, and fertility thing, they are seeing that that's a big concern among women who are in that age, like 20 to 35 age range. And so that in particular, there have been no studies that show any effect on fertility. And even from kind of a molecular theory perspective, there's no reason why the vaccine should cause any sort of side effect like that. And they've seen a benefit, a positive benefit to people who are pregnant when they get vaccinated, that those babies are then born with antibodies against COVID. So the babies are then protected. So all we're seeing from the studies are positive news about getting vaccinated during pregnancy. And there haven't been any studies or any evidence to show that the vaccines could potentially affect fertility in any way. But we know that COVID-19 does affect fertility. So that might be something to let your patients know about as well. Yeah, I think that covers everything. The questionable ingredients, every ingredient that's in this vaccine is also in other vaccines, other than that very particular mRNA part of it. So I think hopefully that will, comfort some people that they're all tested and tried ingredients. And then the mask mandate change. So Serena, if you want to let us know what's haupping with that, because Abbott just announced recently.
He did just announce that local authorities cannot mandate masks, that our schools, when they open back up in the fall, or even over the summer for that matter, will not be able to mandate masks. And so that's of course, and then the CDC has announced that if you're fully vaccinated, you don't have to wear a mask, but if you aren't fully vaccinated, you should. So there's a lot of information floating around out there, and we know that we need to ensure that we're continuing to educate everyone. I know a lot of vaccinated people are still choosing to wear their masks out in public, and that's okay. I think, to Kanaka's points that she made earlier, it's about being supportive of decisions and listening and, helping people get to a point where they can make their own decisions and an educated decision as well. So I think we have to do the same thing around masking too right now, just because it's always been a sticking point for a lot of people, and the more we can just support and encourage and role model is what we need to do.
I apologize. There were some questions that were hidden that I did not see earlier. So thank you all for sticking with us. I know we've gone over time, but just a couple more questions since you waited this long. If a couple is trying to get pregnant, can they both safely take either vaccine? Will it affect their chances of getting pregnant? The CDC has been following this very closely since the trial started way back March of last year. And many, many people have successfully gotten pregnant since taking the vaccines. And so there seems to be zero effect on fertility. Nothing that has been reported from those groups that were in the trials and the women who have gotten the vaccine since the vaccines were made publicly available in December. So nothing that indicates that there would be any effects on fertility. And then if someone gets the first injection but doesn't come back for the second, do they have to start over?
That's a great question. And, originally the recommendation for the vaccines were that you got the Pfizer vaccine within 3 weeks of the first dose, and you received if you got Moderna, you got it within 4 weeks. They've extended that recommendation out to 6 weeks because your immune response, you will still have the same immune response if you get it within that window. However, after what they have said, if you do get that second shot after that 6-week period, there's no guarantee that you're going to have the same immune response as you would if you had received the second shot within that 2 or 3 to 6 week time frame.
Yeah, and they're doing studies now. I think they're experimenting with that time frame. And I saw one study where they were trying it many, like 20 weeks later or something. So they're doing studies to see what the real range is. I mean, I think the 3-week and 4-week range were done for the phases in the trial, the original trials, and that's what we know works. But it's possible that those other ranges might work.
I think that's the difference between the efficacy and the effectiveness of the vaccine. Right now, we're looking at that effectiveness component and the impact that it has on the population to really know what is a reasonable time frame.
And hopefully all of you are getting our COVID emails that go out. They don't go out every Friday, but they go out many Fridays when there's information to share. And so if you aren't getting those, just send us an email at info@texasnurses.org, and we can make sure that your email isn't, that you don't have us blacklisted or something like that. But, you know, as the CDC comes out with that information, we'll be putting it into those emails and get it out to you as quick as possible. And, you know, the second DSHS has some information, we always put it in one of those emails for you. So, yeah, I hope you're all getting that. I think we've answered all of the questions. So please, we'll just stay on for one more minute here if anyone wants to put another question in. There's a question about the references. That email was info@texasnurses.org. And you can also email COVID@texasnurses.org. So we watch both of those. So here's our references, and a lot of these are also included in those emails. And feel free to email us if you want to get any of these specific references. All right, thank you everyone for joining us. We hope that these tips and tools make it easier for you to get your patients vaccinated. Oh, one last question: if someone missed their second dose, do they restart with both doses? Right now, I don't think they're recommending that. So they would just go ahead and get their second dose, and that information might change in the future as they continue to do these studies. All right, thank you everybody for joining us.
Thank you all very much.
Positive comments.
Have a great night, everyone.